Good afternoon. Before I speak, I just wanted to say that I've had a fantastic day. I've enjoyed today far more than I imagined. I don't know why I wouldn't, but I hadn't anticipated finding it to be so much fun and to learn so much and to get so much out of today. So thank you very much. And also just to say, I think my father would have really enjoyed it too. I think he'd have just been quite overwhelmed at the quality and variety of what we've heard about today and what we've all had to share. So thank you. So in the next 15 minutes, what I'd like to do is to tell you about some recent advances in the behavioural sciences, both generally and here in Southampton. Advances that allow us to understand and to support dietary change in young women and their children in ways that may not previously have been possible. So just before he died, my father and I, together with Michelle Lample and Tom Fleming, completed the first draft of this comment piece that was subsequently, after his death, published in Nature. I actually published very few papers with my father, only 5 in total, but he was very excited about this one. This piece sets out the evidence for the importance of having well-nourished young women and children for the securing the future health of nations, and suggests how we might use this focus on young women to develop a new public health. Just a few weeks ago, clearing out his study with Caroline and with Clive, we came across a box file, one of many that lined the walls of his study, as many of you will know. And this box file was labelled The New Public Health. And I got quite excited, because I was quite interested in thinking about what he might be thinking about this issue of the new public health, where his ideas might be going forward, and where ideas that he might have been having that we could then take up. So I was a little bit disappointed when we opened the box file to discover that a very early draft of this comment piece was the only paper in it. But what, of course, it made me realise was that actually this new public health was not his agenda. This was not something that he was planning to take forward, and this was not really, I guess, his big idea. This was something that he left us to pursue and left us to do. And that's really what I think we should do, and that's very firmly where my heart obviously is. So ideas, he left us his inheritance of discovery, but ideas about how to implement this new public health were really ours to take forward. So what is this new public health? Well, aside from the focus on young women and mothers, the other novelty implied by the title is in the finding of new and more effective ways of supporting young women to eat better, to feed themselves better, and to make better choices to feed their children. And also, I believe, to make choices easier, these choices easier for them to make. And there is, of course, a range of ways of improving the nutritional status of young women and children. You can run single nutrient supplementation trials or other kinds of supplementation trials. But if you want to get people to do anything more complex or more difficult to improve their general quality of diet, then and changes that are sustained over time, then you really are talking about changes in behaviour. And this, of course, is where my interests lie. So what we're doing in Southampton is taking these recent advances that I want to tell you about in behavioural science and using them to promote the DOHAD agenda. And we are adding these recent advances to our own discoveries here in Southampton to develop and produce more new and more effective ways of supporting improvements in diets of women and their children, and in so doing promote this new public health. So what are these advances? Well, the first of these advances is in our understanding of the techniques most commonly used to support behaviour change that are actually in use now. Much of our health promotion activity has traditionally been focused on the idea that if you tell people the negative consequences of eating too much or exercising too little, they will then go away and change their behaviour accordingly. Well, this clearly isn't true. And every practitioner and every clinician knows this isn't true, which suggests that our fundamental belief about the role of information and the role of knowledge in changing behaviour is wrong. So if this is wrong, then what do we do? Well, in the inimitable words of one of our Sure Start Centre workers who we met and spoke to, You know you can give me the information, but you can't make me stop eating the 6 cream cakes, can you? I have to make that decision for myself. So giving people information clearly doesn't make, on its own, clearly doesn't make people change. Working out what we do need to do to support change has been helped considerably by the first point on my slide, which is this detailed understanding that we've now achieved of techniques and understanding and classification of techniques that are commonly in use to support behaviour change. And we now have a taxonomy just short of 100 different techniques, documented techniques, and a much clearer idea of which of these techniques works with which type of population and to address which issues. However, interventions just based on these, on changing people's cognitions, the way they think about the choices they make, addresses really only one source of influence on behaviour. Behaviour is, of course, also heavily influenced by automatic processes. That's habits to you and I. And this automatic system, these automatic processes, respond to environmental and social cues in a way that requires very little conscious or cognitive engagement. And it's acknowledgement of this system that has given rise to a new generation of interventions. And this is the nudge approach that many of you will have heard of. The nudge here refers to small changes in the physical or social environment that make people, or that make specific behaviours more likely to take place. Placing fresh fruit on the front of a food display, for example, is an example of a nudge that's going to make people more likely, that we know will make people more likely to choose to help themselves to fruit. So where does this take us on our journey towards a new public health? And how have we developed and applied these advances to our own psychological understandings and our own work here in Southampton? Well, our observational work in Southampton has to date mostly been about understanding the cognitive drivers of the food choices that young women make for themselves and for their family. So our survey work and our focus group studies have established that a woman's sense of control and her sense of personal self-efficacy, that is, her belief that she is capable of carrying out a behaviour and that with the implication that she has the skills and knowledge to do so. So these two factors we know now are very important predictors, independent predictors of a young woman's quality of diet and ultimately also that of her children. We also know that social support, that the priority she's able to give to food and that her belief in the benefits of eating well are also important independent predictors of a young woman's quality of diet. And these quotes from our focus groups really suggest or indicate how difficult and complex some of these young women find their lives and find it practically impossible to make the changes that they know they should be making and actually they want to make to improve their families' diets. This model explains the complex of relationships between the social and cognitive factors that I've just talked about and some others, and their relationship with one another, as I said, and their relationship with quality of diet. This is a simplified version of a structural equation model where the arrows indicate the direction of influence and the significance of the influence of these factors. These are only significant lines of significance. So you can see that a woman's sense of self-efficacy influences her quality of diet by improving her sense of control over life and by influencing her sense of food involvement. That's the priority she can give to food, which again influences her quality of diet. Her expectations of benefit from eating well, the social support she has to eat well are also independently important predictors of her quality of diet. But interestingly, the lack of money that she perceives she has for food doesn't directly influence her quality of diet in this model and in this population. It actually works by affecting her sense of control over her life and thereby her quality of diet. And having understood this, what's really interesting is the finding for us that actually these patterns of influence and these factors don't work equally to influence the quality of diet in everyone. What the dark red arrows indicate is the relationships that are significant only in women of lower educational attainment. So this is women who tended to leave school, who left school at 16, tend to have qualifications only up to GCSE school leaver age, and who also tend to be those who live in more disadvantaged areas. So you can see from the diagram, I hope, that it seems to be more important for women of lower educational attainment than women of higher educational attainment to have higher sense of self, to have a higher sense of food involvement, to have greater perceived control, and to have higher expectations that they will eat, that there will be benefits from them eating better. Because these factors seem to be more critical in this group of women in determining their quality of diet. This graph shows, is again based on data from Southampton Women, and it shows the prudent diet scores separately for women of lower educational attainment, the darker line, and women of higher educational attainment, the grey line, the paler grey line. And it shows their scores, their predicted scores, in relation to their scores on a perceived control scale. And the steepness of the line, the slope for women of lower educational attainment, is an indication of how much more important it is, or how much more significantly, strongly related their perceptions of control are to their quality of diet than in the women of higher educational attainment. And we don't really know why this should be, but we speculate that women of lower educational attainment, women disadvantaged by lower educational attainment, may need to feel more in control and have higher sense of self-efficacy than women of higher educational attainment, because they tend to live and shop in areas that are less conducive to making healthy food choices and to eating a healthier diet. Another work from our group has subsequently confirmed that the determinants of quality of diet seem to operate differently for women of lower educational attainment. So Megan Jarman's PhD work extends this idea into how women feed and parent their children too. She found that women who were more psychologically resilient, and this is a description that encompasses their sense of self-efficacy and their sense of personal control over life. She found that these women employ more strategic parenting and have children with better quality diets than others. And in the mirror of our earlier finding, she found that this psychological resilience is more important in determining quality of diet in children of mothers of lower educational attainment than it is in mothers of higher educational attainment. These mothers need to be more resilient to have the same impact on their quality of diet. And this is also confirmed, this pattern of findings is also confirmed in work produced by Christina Black as part of her PhD work with Janice Baird, also in our group. And they graded the place where each woman did her main food shop on its healthfulness, according to a detailed assessment devised by Christina and Janice that included the variety, quality and price of a range of healthy and less healthy food types, food products on sale. And when they looked at the relationship between the healthfulness of where women chose to shop and their quality of diet, they found that the healthfulness rating of the shop only positively affected quality of diet in women with lower educational attainment. The quality of diet of women who were disadvantaged by lower educational attainment declined with the healthfulness rating of the food store in which they were doing their main food shop. Whereas the diets of women of higher educational attainment who chose to shop at stores which stocked less healthy food products had diets that were more resistant to this less healthy food environment. And this is all evidence, as we see it, for specifically targeted interventions to improve the nutritional status of poorer and more disadvantaged women specifically. It appears they may be particularly susceptible to the effects of the food environment, and that they need to be more than averagely resilient to maintain a good quality diet for themselves and their children. So how have we then used these insights to develop intervention strategies here in Southampton, and how do we plan to take this intervention work forward? The particular support needs of women with lower educational attainment were addressed by the Southampton Initiative for Health. It drew on all our work looking at the cognitive drivers of cognitive determinants of quality of diet with women and their children, and it was designed in partnership with the Southampton City Council and Southampton City PCT as it was then. Working through children's centres and working with Sure Start Children's Centre staff gave us access to women and children from disadvantaged areas, and the relationship of trust, and we used the relationship of trust that Sure Start Centre workers had developed with women attending centres. We gave them training in healthy conversation skills. This is a model of behaviour change support that draws on other models of empowerment. And rather than telling women what they needed to do to sort themselves out and to improve their diets, the skills that we trained them in provide practitioners with a style of engagement that really starts with the woman's own agenda. It starts where she's at and with what she wants to change and how she feels she might be able to enact those changes. This approach works on the cognitive determinants of health behaviour we've already identified in young women, and it uses some of the effective behaviour change techniques that I mentioned earlier on. The value of this training type approach of existing bodies of staff to deliver behaviour change support rather than a bunch of psychologists is that it has the scope and the reach that a programmatic intervention could never have. And it helps us or enables us to address public health problems at scale. It's the kind of thing we were talking about, the kind of approach we were talking about in the Nature comment that I talked about right at the beginning. However, one of the difficulties of intervening on this kind of scale is ensuring that women had a sufficient dose of our intervention that we might expect to see change. So we're now testing the efficacy of healthy conversation skills in improving the nutritional status of pregnant women, and this is the SPRING study. Behaviour change support is being delivered by MRC LEU research nurses trained in healthy conversation skills as part of a randomised controlled trial in which pregnant women are also being randomised to vitamin D or placebo. It's an extension of the Mavados trial that Cyrus talked about earlier. But this approach to supporting diet and lifestyle improvements in women and children has been adopted by a number of other projects and studies around the world, both in the UK and around the world, I should say. We are training trainers, we're equipping trainers in the Wessex region to train frontline health and social care staff to support behaviour change on behalf of Health Education Wessex, to support them in the delivery of the UK government's Making Every Contact Count. So the idea that every time you go and see a health and social care practitioner, they will support you to think about your the lifestyle that you're leading and the effects that might be having on your health. We're working with Shane Norris, who's here today, in South Africa, training community health workers to support lifestyle change in adolescents. And we're working with Gravida at the University of Auckland, funded by the New Zealand Ministry of Health, to support the maternal and child health workforce in skills to support behaviour change to improve maternal and child health across the board in New Zealand. And I have to say now that much of this work is being done by my long-term colleague Wendy Lawrence, supported by Tanaz Tanati and Rufia Begum, also of our group. However, healthy conversation skills is primarily an approach that to behaviour change that operates at the reflective cognitive level that I mentioned earlier. What about interventions that operate on this automatic system, the nudge type intervention, and use manipulations of the environment to change behaviour? Well, because of the theoretical literature suggests that both approaches and used in combination are likely to be the most effective to operate on both systems simultaneously. Christina and Janice are using their work on the food environment in discount supermarkets as the basis for designing a multi-level intervention that attempts to modify the choice architecture of these supermarkets, but at the same time to use healthy conversation skills to support individual women to make changes to their diets. So that's where we're going with the future. But I should also say that there are elements of the project that Shane is running or planning that in South Africa that also target the environment, though he's more specifically targeting the social rather than the physical environment. So watch this space for that. Those results. So in conclusion, I also have chosen the same section of my father's address at the MRC centenary event. I think about this a lot, and for me it epitomises where I feel we need to go and the justification for why we do what we do. And I hope that during this talk I've been able to demonstrate that we are now in a position to make real progress in finding new and more effective ways to support young women feed themselves and their families better, to prevent disease and to improve the health of generations to come, and to enact this new public health that was driving the generation of that last Nature article and has driven me ever since. So I think that if Dad was alive today, I hope there would be a few more papers in that box file of his. I'd like to think there would be anyway. Thank you very much.